I just wanted to thank everyone for joining us today for our webinar. Today's webinar is sponsored by the Oncology Nutrient Dietetic Practice Group. The topic is Two Worlds Collide, Cancer and Eating Disorders. And our presenter today is Erin Holly. Before I introduce her, just a few housekeeping tips. The first is just a reminder to please keep your lines muted. We have a few hundred people on the call today, and so to minimize any background noise. So far, WebEx is cooperating, and it's letting me mute everyone, but just make sure if you do hear any background noise, please just move your mouse around the bottom middle of your screen and make sure that that little microphone icon is red to ensure that you're muted. The slides and the CEU certificate are posted on our website already. They are at www.oncologynutrition.org, and I will send out that link here in a moment in the chat window. They are under the Member Benefits tab at the top, so you will need to log in to be able to access those. And so again, I want to thank Erin for speaking to our group today. Erin is a registered and licensed dietitian in the state of Ohio. She received her bachelor's degree in dietetics from Miami University and her master's degree in food and nutrition from Bowling Green State University, where she completed her dietetic internship. She joined the team at the Ohio State University James Cancer Hospital in October of 2016. She works primarily with breast cancer patients and survivors over the past 2 years. And in addition to her role in oncology, she also has an eating disorder clinic here at the medical center, where she currently sees adults with eating disorders. Erin has over 13 years of experience helping individuals overcome eating disorders, emotional eating, and body image distress. Her career initially took her to Phoenix, Arizona, where she stayed for 7 years, working in residential, inpatient, and outpatient settings. When she did return to Ohio, she worked at Cincinnati Children's Hospital Medical Center, again specializing in eating disorder treatments of adolescents and children. She loves educating individuals about the benefits of healthy eating and lifestyle habits, and she is incredibly passionate about teaching mindful eating and intuitive eating concepts to everyone. So she's going to be talking to us today about what happens when two worlds collide. And with that, I will turn it over to you, Erin.
All right. Thank you, Amy. And thanks for everyone for joining me today. I'm really excited to have this opportunity to share with you a subject and population that I'm very passionate about. I have no disclosures to report. And the objectives for today, by the end, you should be able to identify basic criteria of eating disorders, be able to identify causes and functions of eating disorders, and to summarize treatment goals with eating disorders. The outline for today will start by covering the DSM diagnostic criteria for anorexia nervosa, bulimia nervosa, and binge eating disorder. We'll discuss causes and functions of eating disorders, the dietitian's role, before we get into some case studies, and then at the end I will leave time for questions. So let's get started with the DSM. So if you're not familiar, the DSM-5 is the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders. It helps to define diagnostic criteria for hundreds of disorders, including eating disorders. And the 5th edition was published in May of 2013. So according to the DSM, anorexia nervosa is described as an intense fear of weight gain, a refusal to maintain a healthy body weight, and distorted body image. And the common signs and symptoms that you're likely to see are calorie restriction, an obsession with food, weight, calories, or dieting, an intense fear of weight gain or being fat, a refusal or avoidance of certain foods or entire food groups. And I've often seen this in a lot of my oncology patients too, especially with all the fear mongering that happens in the media. This is pretty common. There's often a denial of hunger or weight loss. There can be strange eating habits or food rituals. And the way that I describe food rituals, if you're not familiar with that term, it's often performed to help reduce anxiety with eating. It might be a particular way of eating. It can be things such as tearing food into small pieces, taking really small bites, not allowing food to touch on their plate, or using excessive condiments to cover up the taste of food. Those are just some examples of food rituals. You also might see excessive or compulsive exercise, withdrawal from family, friends, and activities. Isolation is just a really big part of an eating disorder. And then often fatigue, cold intolerance, dizziness, hair loss, or thinning. And then the other criteria I didn't put on here, what I think is important to mention, as we'll see it in my case study later on, is the characteristic of perfectionism. With bulimia nervosa, it's characterized by a pattern of binging or eating a large amount of food in a short period of time, more so than what a typical person might consume. There's often a sense of lack of control and a compensatory behavior to prevent the weight change. So common signs and symptoms of bulimia would be binging or purging more than once a week for up to 3 months at least to fit the diagnostic criteria. And purging could be many forms. It might be self-induced vomiting, use of laxatives, diet pills, diuretics, exercise, or even insulin misuse. You might see swelling of the jaw or cheeks, discolored teeth, calluses or sores on their knuckles. Presence of dental caries would be present too. I've had several patients actually who have told me that their dentist was the first one to detect their eating disorder because of dental caries and dental erosion. There's often evidence of binges around, maybe food disappearance, wrappers in the trash, or hidden food. And usually a family member might be the one to hint at this instead of the patient themselves. There's typically a feeling that they're out of control with food or shame after eating. And there's fear of weight gain. And the self-esteem is typically tied to body image. You might see a very chaotic relationship with food. More so in bulimia, you might see that their relationship with food can mimic some factors in their lifestyle. It's not completely uncommon for someone with bulimia to also struggle with a drug or alcohol addiction, and therefore their relationship with food might look very chaotic or unstructured, just like the addiction. And then similar to anorexia, you'd also see withdrawal from family, friends, and activities. The next one I want to talk about is binge eating disorder. And the DSM-5 was actually the first edition to include binge eating disorder as an official diagnosis. And it's characterized by recurrent binge eating episodes of at least once a week for 3 months or greater, combined with a feeling of lack of control and intense shame and guilt. Again, common signs and symptoms would be eating more rapidly than normal, eating until uncomfortably full, eating large amounts of food even when you're not physically hungry, eating alone due to feelings of embarrassment, and feelings of disgust, shame, and guilt after eating. So unlike bulimia, binge eating disorder, there's no compensatory behavior after eating. And this again is one disorder that I've seen repeatedly in a lot of my oncology patients. So the next one I want to talk about, it's not an official DSM diagnosis, called orthorexia. It's common in the eating disorder field, and it's becoming more well known in the general population. And it comes from the word ortho, which means straight or right. So it's described as a right way of eating, or really it's an unhealthy obsession with eating healthy. So common signs and symptoms that you might see with orthorexia are compulsive checking of ingredient lists and nutritional labels, increased concern about the health of ingredients, cutting out an increasing number of food groups such as sugar, carbs, dairy, meat, animal products, etc., an inability to eat foods that are not deemed healthy or pure, showing high levels of distress or anxiety when safe or healthy foods aren't available. They may even avoid social situations if they know the food ahead of time will not fit their criteria for eating. There may also be an obsessive following of health food or lifestyle bloggers on social media. They might really be into the Fitspo or the Thinspo social media followings. And typically with orthorexia, body image actually is not typically a concern. It's often separate from that. An additional thing that we might see with orthorexia is an increased concern about taking supplements, herbal remedies, eating organic foods, etc. So if you're like me, you're probably saying, I see a lot of patients like this in our oncology population that might fit this definition. And what I want to clarify is that there's nothing wrong with having an interest or concern about healthy eating, especially for our patients and cancer survivors. But the main concern with orthorexia, just like anorexia, is that it can quickly lead to malnutrition by restricting or limiting the food variety that is consumed. That's when it becomes a problem. So let's move on to talking about typical causes of an eating disorder. And if you see the ones in bold, I went ahead and marked those as typical things that I've seen in some of my oncology patients. So there's often a biopsychosocial component to how eating disorders develop. So some of the biological components could be genetics. If there's a strong family history, it can indicate 10 times more likely for an individual to develop an eating disorder. Also, as they're developing, hormones and brain chemicals can play into the development of an eating disorder. Psychological causes could be low self-esteem, depression, anxiety, anger, or loneliness. We may see a history with physical, emotional, sexual, or spiritual abuse. Maturation fears, which may not just mean the fear of growing up, it could also be a fear of separating from family. There's perfectionism or the quest for perfection, and feelings of inadequacy or lack of control in life, and impulsivity. Social factors might be cultural pressures of thinness and obtaining the perfect body. Now more than ever, I feel like there seems to be cultural pressures to achieve this ideal body. The media seems to go from the thin ideal to now we work more towards this fit ideal, which still promotes an unrealistic standard of beauty. There's also might be narrow definitions of beauty that include only weight and shape, again, typically coming from the media, but this may also come from family members too. There could be teasing, body shaming, fat shaming involved, troubled personal or family relationships, and difficulty expressing emotions and feelings. And then other causes might include age. Most eating disorders, again, not all, but a lot of eating disorders develop around adolescence or early adulthood. And then again, in most of the oncology patients that I've seen who may also fit criteria for eating disorder, it tends to be an event that's re-triggered later in life. But the initial onset may be younger. There may also be presence of other emotional disorders, like OCD, anxiety, depression, low self-esteem, a history of dieting or extreme dieting. Maybe they've been on 20, 30 diets before, and that kind of encouraged eating disorder behaviors. Overweight body size may contribute to an eating disorder as well, or the use of or abuse of laxatives, diet pills, diuretics, vomiting are much more common. Sports and athleticism can also lead to some individuals seeking an unhealthy weight to meet certain standards in sports. And then transitions or sudden and stressful transitions. I've often heard that eating disorders are not caused by one factor alone, but it's the culmination of many events or circumstances leading to the perfect storm. So we may even see several causes in our patients. And especially in our oncology population, I think it's important to recognize general causes of eating disorders, as these are likely to be re-triggered later in life when the cancer diagnosis comes. So moving on to functions of an eating disorder. Again, I've bolded the text that I've seen commonly in some of our oncology population as to functions of the eating disorder. So in addition to causes, it's equally important for us to begin to understand the function in order to better help our patients. So it's typical that they might use the eating disorder as a means of coping or control, a means of comfort, can often be a friend or a substitute for relationships, can be a way for them to express emotion without having to verbally say anything, can also be a way to numb or to isolate, and can definitely be a call for help. I also just want to touch on this picture. I think it's important. I really like this picture. I've had many of my patients actually describe their body image as very similar to this picture, where they are physically malnourished and extremely underweight, but in the mirror, their body image is so distorted that they continue to see themselves as being overweight or obese. So what's our role as the dietitian? As most of you know from being in the field of oncology for several years, we're not really just the dietitian. We wear many hats with our job title. The same is absolutely true for the treatment of eating disorders. We play the role of nutrition therapist and nutrition educator. We're often a role model. We play the clinician role where we monitor their weight patterns, calories, and activity. We help them to establish a meal plan or eating pattern. We're there to provide accountability to the client and also to collaborate with the treatment team, whether this is the therapist, the doctors, psychiatrists, nursing, etc. And with our oncology team, this may even be further expanded. So let's start with talking about what it means to be the nutrition therapist. Again, we really are counselors as dietitians. Each of us may not have as much experience with this, but we can also demonstrate active listening and appropriate feedback, such as in motivational interviewing. It's important to ask questions to know what they would like to accomplish with treatment or how to help them best. We can help them to strategize goals throughout not just their oncology treatment, but maybe if they're struggling with their eating disorder, strategize goals to help them meet those treatment outcomes as well. Another role as the nutrition therapist might be to help them understand and apply the functions of an eating disorder. This can be incredibly helpful for the client. For example, if the eating disorder functions as a means of control, we can begin to talk to them about what are some other ways to help you feel in control without jeopardizing your health, or what are other ways to connect with your feelings and express yourself without using food. We're also here to convey sensitive material. So by this, we may have to talk about specific weight gain goals or sensitive areas of treatment. Please don't feel like you have to tiptoe around the eating disorder or ignore the elephant in the room. I've talked with many dietitians who don't have as much experience with eating disorders, and they're terribly afraid to say the words eating disorder to a patient. Let me tell you, usually the client is well aware that they have an eating disorder, so you're not telling them anything new, especially if they've already communicated this to you or another staff member. It's also important to be forward with our patients when we convey appropriate information. Don't feel like you can't share recommendations for weight gain just because you're afraid of how they may interpret it. It's our clinical responsibility to share appropriate treatment recommendations with our clients in the best possible delivery. It's not our responsibility to make sure they're emotionally okay with our recommendations. How they interpret the information is up to them. And it's also their job to communicate that with us as the provider. But I would encourage you, try using words such as weight restoration instead of weight gain. Or maybe using the words appropriate weight instead of ideal or healthy weight. It's also okay to ask the client themselves what terms that they would prefer you to use. The reason I say this is because I've had many of my eating disorder patients tell me that the word healthy equals fat to them. So I don't want to continue to use that in conversation. So it's absolutely appropriate to ask them yourself. And last, as a nutrition therapist, I really believe it's our job to be a role model. I'm a very strong believer in the idea of practice what you preach. I believe that it's just as important for us to demonstrate normal eating behaviors to our clients. This rule definitely applies to our oncology population as well. If we're only eating clean foods or cutting out sugar, carbs, or dairy because of fear, how can we empathize with our clients and expect them to broaden their choices? I believe it's so important for each of us as a clinician to evaluate our own relationship with food and seek help if we find ourselves struggling with fears or concerns about food. Next, the nutrition educator role. So again, it's our job to help establish goals. This is our clinical responsibility to help set appropriate weight and calorie and activity recommendations. But keep in mind, it may not always be appropriate to share this with the patient too. If a client asks, what should I weigh? Or how much do I weigh? And you know they have a history of an eating disorder, one thing I do is ask them, how will this help your recovery process if I give you this information? Or I might say, if it's okay with you, I'd like to keep that information to myself as the healthcare provider, as I'm trying to do what I believe is best for you. It also might be appropriate to ask the team not to share weight information with a patient if they have a history of an eating disorder. Unfortunately, patients don't always advocate for themselves and tell providers when it's not helpful to be weighed. So if you know this ahead of time, it might be good for you to go ahead to your team and say, please don't let them know their weight. It would be better if you talk to them in an individual session or wait for the therapist to share that information if you're not comfortable doing so. Another important thing to discuss as the nutrition educator is the role and function of carbs, fat, and protein. The reason I put this up there is really because I've had so many patients who are confused about what our body does and how it digests and utilizes nutrients from carbohydrates, fat, and protein. I often have to tell patients that there's not a separate pathway for the way that carbs in a cookie versus carbs in an apple are digested. A cookie doesn't go to your hips versus an apple to your bicep, which is why I included the ad above. Oh, sorry, you can't see it. I will send it out later. It's a Nutri-Grain bar ad. It, I think, was from the early 2000s, and they had a picture of a woman with cinnamon rolls on her butt. And I seriously used to get patients who thought that that was the way that their body digested food. And again, I believe as the nutrition educator, it's our role to help dispel these myths about how our body utilizes food. I also like to tell my clients that their body has no clue that a cookie should be scary or bad for them, or maybe it's bread or dairy should be scary, that's the eating disorder talking. And this is where we get to help dispel myths and lies about food. We do this every single day with our oncology patients. We have to help them fight lies about miracle cures or new undiscovered natural treatments, quote unquote. So this is a very important role that we play. Another job is to educate about medical side effects of eating disorders. So oftentimes they may see heart arrhythmias, electrolyte changes, especially with refeeding syndrome. They might see edema, ulcers from consistent purging, digestive issues, constipation, muscle loss, etc. And then also we manage other diseases. What I've learned quickly in the field of oncology, I'm not just treating one thing. In addition to cancer, I'm often treating them for diabetes, IBS, Crohn's, food allergies, the list goes on and on. So how do we implement all of this? And what's the best approach? So what I found in 13 years of experience in the field of eating disorders is that this is the best philosophy, the idea that all foods can fit. I believe that all foods fit truly in balance, variety, and moderation. What I want to clarify here is that I'm not saying that all foods are equal, but that all foods fit. I believe there's a place for cookies just as much as there's a place for apples. So it's really important to continue to hone in and make sure they understand the ideas of balance, variety, and moderation. The next thing I encourage you to promote is that there's no such thing as good foods or bad foods. The reason I personally don't like this is because good and bad implies moral value. And I don't believe that food in and of itself has moral value. And what happens is typically if we assign moral value to food, we often transfer that to ourselves, or clients may transfer it to themselves and label them as good or bad people because of the food choices. So what I often say is you're not a good person because you ate an apple, nor are you a bad person because you ate a cookie. What you eat or choose not to eat has absolutely no impact on your character and value as a human being. You're not clean or dirty or pure or organic because of your food choices. Food does not determine your status or character as a human being. We have to separate the two. The other thing is that labeling foods as good or bad can also create unnecessary guilt with eating. Or I often refer to this as inappropriate guilt. I have a friend in the field, she's a dietitian also, and she likes to tell her clients that there's really only 2 reasons you should ever feel appropriately guilty for eating, and that's if you stole your food or if you hurt someone to get it. Otherwise, it's completely inappropriate guilt. So it's also our job to promote normal eating. And the way that I define normal eating is the careful balance between eating for enjoyment and eating for nutritional value. I believe that both have to be present in normal eating. If we have one or the other, we often find a disordered relationship with food. So again, normal eating is typically a healthy balance of carbs, fat, and protein. Typically does not involve diet products. I do not recommend diet products of any kind, especially with a history of an eating disorder. This only feeds into the idea that certain foods are better for you than others. So I do tell my clients to avoid fat-free, low-fat, low-calorie choices if possible, unless they naturally come that way, like yogurt is typically low-fat. I'm fine with that. And the end goal is always intuitive eating. If you're familiar with Ellen Satter, she has a wonderful definition of normal eating that I've been using for years in practice with my eating disorder patients. And I just found it the other day again on Google. So if you just Google normal eating definition by Ellen Satter, you'll find it, and it's wonderful. So treatment goals are going to be similar with our patients with eating disorders as what we would want for our oncology patients. We want to help them nourish the body with proper nutrition and cessation of disordered behaviors. We want to help them achieve a healthy body weight or weight stabilization, to decrease fear and anxiety with food, and to establish an appropriate exercise plan. So this nutrition prescription, I just want to say, is likely to be used more for the underweight or possibly the patient who struggles with anorexia. Some of you do this every day for your oncology patients. Maybe you're in the head and neck population and you're used to calculating needs for underweight and the needs for weight restoration. But I just wanted to include this slide in case it's helpful in working with eating disorders. So the one way to start is to determine calorie needs based on height, weight, BMI, also based on weight history or growth history, depending on the age that you're working with, and 24-hour recall. So typically I would start based on recent intake and increase from there. If they've been taking in less than 1,500 calories, we do know from research that it's absolutely safe to still start with about 1,500 calories a day. And then you want to work towards maintenance calories first. What I really feel is appropriate is trying to use food first when possible in working towards a maintenance calorie level. And then we want to slowly increase for weight gain as needed. And I did put inpatient and outpatient recommendations up in the table that you could see for weight gain progression. So for inpatient, it's appropriate to increase 200 to 300 calories every 2 to 3 days. And for outpatient, it's likely to be a little bit slower, so maybe 300 to 400 calories every 1 to 2 weeks. So touching back on weight gain and working towards maintenance calories, what I typically recommend, and this is just my own personal opinion from being in the field, that I really prefer and recommend people work towards maintenance calories using food first. And then if a client needs additional weight restoration beyond that, I prefer to use supplements, oral supplements, or tube versus food. And let me explain why. The reason for this is that food for weight gain can often feel like they're binging their way out of an eating disorder. Or it honestly may trigger past experience of binging, or they may have a strong fear of overeating. And by using food fully to restore, it may just feed into that fear or past experience. So often if the patient has a history of binging, I would recommend that you use supplements or tube feeding instead of food to refeed. And this would be especially if they're going to need maybe greater than 3,000 calories a day. Other than special circumstances, like if we're refeeding for a male who might typically consume more than that a day, it may be appropriate to use food to some extent. So here's a case where we can use our best judgment, but I just wanted to give my little disclaimer as to why I would prefer food to reach maintenance calories and then supplements or tube feeding beyond that. And in the case of someone who may start off at normal or overweight, it's recommended to stabilize their weight before pursuing weight loss. The ideal is that they work towards decreasing eating disorder behaviors before weight loss would be a goal. So another way to implement this would be, again, to promote normal eating always. So this might be 3 meals a day. It also might be 3 meals and 1 or 2 or 3 snacks. And often I do this, especially with my oncology patients, it could be very basic, such as using the New American Plate as the guide to explain what a normal meal might consist of. Or it could be more structured, such as explaining that you need 2 to 3 ounces of protein, 1 fat, 1 to 2 servings of whole grains, and 2 fruits or vegetables per meal. Again, that's if needed based on the client and what you feel is appropriate. We also want to add fear foods when it's appropriate. And I think it's good to always let the patient know in advance that you will be making a plan to reintroduce fear foods slowly and as they're ready. And one way that I've done this is to have the client create what's called a fear food hierarchy. So you might have them identify their top 10 fear foods, start with the least scary on the bottom, and work your way up. So maybe we would set a goal, for example, to introduce one fear food, their least scary, at least one time before I see them again, perhaps in 2 weeks. And once they become more comfortable with that, we'll work our way up the hierarchy. Patients may actually need to eat with a support person or a safe person if that would help them to finish their meals or complete it in a more appropriate time. So you can suggest that. If patients struggle with identifying hunger and fullness, you could consider assigning specific meal times, like breakfast is at 8, lunch is at 12 or 1 o'clock, and dinner will always be at 5, to help them until hunger and fullness are more understood. You may also use a timer to help with pacing. It's not uncommon for someone who struggles with anorexia to pace very slowly, meaning it might take them anywhere from an hour to 2 hours to complete a normal meal. So setting a timer can help give a time frame of what's appropriate. The other way I've seen this used appropriately is a timer to help with those who struggle with binge eating. This can help them draw out the length of a meal. I've had patients who might consume a meal within 5 or 10 minutes, and I want to extend that to be at least maybe 15 minutes to start with, the goal getting up towards 25 minutes. And again, I don't recommend counting or talking calories with patients who have a history of an eating disorder. It's just typically not helpful for them. There are, of course, special considerations in there, but in general, for this population group, I would say avoid it as much as you can. So I wanted to include this slide of what not to say, mostly because I've put my foot in my mouth many times working in the field. So if I can spare any of you some of the same embarrassment I've been through, then I want to do so. So here are some things that you probably should not say to someone with an eating disorder. You look healthy. I would encourage you to try to avoid all appearance-based comments in general. The next one, you don't look like you have an eating disorder. Truthfully, eating disorders don't discriminate. They affect people of all races, genders, ethnicity, body size, etc. There's no way we can ever look at someone and tell that they have an eating disorder. So that's not something that's good to say to somebody. Another thing I've heard is, I wish I had your willpower. Why can't you just eat, or why can't you just stop eating? If it were that easy or that simple, they would have done it already, and they wouldn't need your help, and they wouldn't need treatment. The idea of I shouldn't eat that, or do I look fat, or I feel fat. Again, those are just not the best things to say around someone who has a history of an eating disorder. Working in the field, and often when I tell people that I've been working with eating disorders for over 13 years or for most of my career, unfortunately a typical response is, oh, I wish I had an eating disorder. I need to lose weight. I don't say this in response, but oftentimes I want to say, really? You wish you had the leading cause of death among all psychological disorders? I don't think so. I say these things because I want us to be more aware of what we say to clients, aware of how it may be perceived. If you do accidentally say something inappropriate, just apologize. Trust me, like I said, I've stuck my foot in my mouth so many times that it's humbling. And this is how I can be here today to help you all do a better job at caring for these patients. All right, so some case studies. So this is a client I worked with a couple months ago. Here's just general data, 67-year-old female with history of endometrial cancer and 1 year of remission. She has a past medical history of Barrett's esophagus and a history of colon cancer. She's 5'7", 239 pounds, and a BMI of 37.5. The initial referral from the doctor was to see me for weight loss. At our first meeting, she presented with binge eating behaviors daily for the past 6 months, and she admitted that she was binging 2 to 3 times a day, and that the binge was typically 1 to 3 hours in length. Her food of choice was cookies, and she did tell me that cookies are her friend. So I wanted to put that in this slide because that points to the function of her eating disorder. She was using it as comfort, as a relationship, as a way to isolate, and a call for help. The other important notes I put in here, just so you have a little bit more detail about her, is that she and her husband were trying to follow a low carb or ketogenic diet. She was skipping breakfast and drinking bulletproof coffee, and had recently been the caretaker for her mother-in-law, who recently passed. So now she was trying to fill her time and basically find herself again and rediscover who she was. She was also enrolled in a 6-week mindfulness course at the same time. This was apart from our meetings. So these are some hands-on activities that I did in particular with her, and I wanted to give these skills to each of you today. So this is probably one of my favorite analogies and tools that I use with patients. And I call it the fire safety plan or the house on fire plan. And I literally do draw it out for patients on a piece of paper. It looks kind of like a second grader's house, but I don't care because they get the general idea. So the whole idea of a fire safety plan, if you're creating it for yourself, is that in the event of a fire, we initially want to get out of the location or get out of our house. We want to get to a safe location, to call for help, and only return when it's safe. I give patients this tool because I want them to treat or view their binge behaviors or eating disorder behaviors as a true emergency. It really is an emergency to their health. So they need to get out of the room that they're currently binging in and get to a safe location. And I always encourage my patients to map this out ahead of time, to think through this when they're in a logical state of what are your safe locations. Maybe it's another room in the house. Maybe it's outdoors if it's nice weather. It's not going to be a grocery store. Maybe it's the library, things like that. But they need to think through a safe location. They also need to think through who they're going to call for help. So in this patient's case, it was texting a friend or texting her husband. And I often tell them to have multiple people on your list in case someone's not available. It's not okay to just have one single person. But I also tell them it's up to the individual how much they share with the person. Not everyone has to know about the eating disorder or why they're struggling, but they might want to have a heads up if they text or call them late at night, for example. And then the last part is return when it's safe. So in working in a treatment center, we often describe this as urge surfing. So if you think of a surfer riding waves in the ocean, they have to ride the wave out. And that's truly what they have to do with eating disorder urges too, is ride out that wave. Because what we know about anxiety in our body is that our bodies cannot stay in heightened states of anxiety for long periods of time. Therefore, we have to sit and ride it out. This next drawing is another one that I often do for patients. And I call it the pathways of change, or we can think about it as the neural pathways in our brain. So oftentimes patients have a very common road that they travel down in their brain. So for instance, for this patient in particular, whenever she felt isolated or needed comfort or a call for help, her road took her, let's say, to road A. When she felt isolated, she would binge. And that was a very familiar road to her. This might be like the road we travel to get home. Sometimes it's so familiar that we pull into the driveway and we have no idea how we got there because we're just on autopilot. And that's really how our patients feel too with eating disorder behaviors. It's such a familiar road. So recovery is about finding a new pathway. So I talked to her about finding pathway B, for example, that instead when she starts to feel like she needs comfort, or a call for help, I want her to choose a different path, maybe a way of taking care of herself or meditating or something like that. And in the beginning, I like to explain that pathway B is not going to be smooth like A is. It's not that well-driven highway that has new pavement on it. It's often like a bumpy country road. There's lots of potholes in it. There might be tree roots growing over it. It's not uncomfortable. But what happens is the more we travel down road B, the smoother it gets, the more comfortable it becomes. And what happens to A then is it starts to get some tree roots grown over it, and that becomes less familiar. So it's really important to describe this for our patients. And she in particular was very receptive to both of these tools. And once I drew them out for her, she said it made absolute sense, and it kind of helped her see the importance of trying new things. So we worked together for a couple months. She was able to explore ways to rediscover herself after being the primary caretaker, and she learned new ways to distract herself. She also began to limit her screen time with games. She set boundaries on where in the house she was able to eat, and this was all her. She decided to do this on her own. She decided the kitchen was for eating, the office was for working, bedroom for sleep, etc., so that she only had one place to eat food, and that was more out in the open. She wasn't able to isolate more. She began regular meditation to help relax and soothe instead of binging. She implemented mindful eating techniques and gained confidence as she went longer and longer without a binge. And that by far is the coolest thing to watch, is to see someone gain confidence that they're actually able to overcome their disordered behaviors. I also would like to report, because I'm speaking to a group of dietitians, that she did decide that the ketogenic diet was not for her, and she decided that she wanted a more balanced approach for the rest of her life. So the next case study, this was a 70-year-old female with a history of breast cancer, diagnosed in 2008. She has a past medical history with high cholesterol, diagnosed in 2003. She's pre-diabetic in 2014, also with a history of anxiety and now osteoporosis on a recent DEXA scan. She's 5'7", 95 pounds, and a BMI of 14.8. So as you can see, she was incredibly underweight. The referral status from the doctor said unable to gain weight. She presented with a 1-week diet history. I put in quotes that it was neatly written because this was important to me, as she presented with some characteristics similar to anorexia with the perfectionism tendencies. She may also fit into the orthorexia category too. She had extreme food restrictions, did not allow fat in her diet, no added sugars or desserts. And this really fed into the functions of her eating behaviors being control, coping, and possible relationships. So I included her diet history so you could see what she typically ate in a day. And this was almost what she ate every single day. She had very little variety in her diet. So she often had Cheerios or Kix cereal with skim milk and a banana for breakfast, a turkey sandwich on 100% whole wheat bread, fruit, and skim milk for lunch. Occasionally, she would allow herself a slice of cheese or relish on her sandwich. Otherwise, she had no condiments whatsoever. Dinner was a lean cuisine or a healthy choice meal because she did not cook, with fresh fruit and skim milk. And snacks might be fresh fruit or edamame, or soda crackers if she wanted a treat. And that was really what she actually said to me, that they were a treat for her. She could not remember the last time that she had ice cream. Her beverages only included water. She was not allowed, according to herself, to have coffee, tea, soda, etc. She was extremely restricted in her intake. So in this case, I had to play the role of nutrition educator. We talked through how low weight and osteoporosis are commonly linked, and I encouraged her to to restore weight. And that was actually a goal of hers, to gain 10 pounds. So we talked about adding healthy plant-based fats, such as nuts, nut butters, avocado, olive oil. I encouraged her to switch to low-fat dairy versus fat-free, and encouraged her to have dessert at least twice a month. We even discussed the possibility of Glucerna as an option because she was so concerned about added sugars in her diet that she was not willing to make any changes. Unfortunately, the patient declined all of these interventions with me and declined any other follow-up, despite further requests from myself and from her oncology team. She returned about a year later to this clinic and continued to refuse recommendations. And her osteoporosis had actually worsened, unfortunately. And I know this is kind of a sad case study, but I wanted to include it as really an example of orthorexia, possibly. Again, as a dietitian, it's not our job to diagnose necessarily, but the signs were there that whether it was anorexia or orthorexia, she was clearly struggling. But we also can't force someone to get better. So I hope this has given you some good knowledge and understanding of eating disorders and maybe how to care for your oncology patients better. I really appreciate you sticking with me, and we've got some time for questions, so thank you.
Excellent, Erin. Thank you very much. Again, we do have about 10 minutes or so for questions, so I have a few coming in right now. We've had a few people who have asked about some additional resources, either websites or books that would be specifically geared towards eating disorders, and if you have any that are geared towards eating disorders and oncology, that would probably be even better. But any thoughts on some references for this group?
Yeah, so the main things, the books that I recommend the most are Intuitive Eating by Evelyn Trivoli and Elise Rich. Most of us are familiar with that. Health at Every Size by Linda Bacon is a wonderful resource as well. Big Fat Lies by Glenn Gazer. These are all books, by the way. If you're interested in learning more about orthorexia, there's a book called Health Food Junkies, written by Stephen Bratman. And that I read that several years ago and just gave me great insight into what orthorexia really looks like. And then another one that I've really used in the beginning of my career was called Moving Away from Diets by Nancy King and Karen Kretina.
All right, thank you. At what point do you think you would refer a patient with maybe some signs of an eating disorder to a higher level of care or to a specialist?
Yeah, great question. I would say if you're noticing that their behaviors are not improving, if the behaviors are consistent, whether that's struggling with food restriction and they're not getting better, or with continuing or ongoing binging and purging behaviors, and again, not getting better maybe after a month or two of working with you or the team, it's okay to refer them to a higher level of care or a specialist.
All right, thank you. Let's see. How do you respond to someone, especially if you were in a group setting like a support group that is talking about calories, not necessarily in an eating disorder group, but when they're maybe putting the focus in the wrong place? Like, how would you respond to that and make sure that you're getting the bigger message across?
That's a great question. I would probably just gently jump in and remind everyone that calorie needs are different for each person, and therefore it may not be the most helpful to talk about your specific calories or what you're following. And again, just reiterate that each individual is so different. It's important to focus on their own goals. And you could also say, if you as the dietitian are helping to lead this group, you could also add that you might be happy to meet with them on a personal basis instead of in a group setting. All
right, great suggestion for that. Besides educating on the negative psychological impact of the unintended weight loss for certain cancer treatments, how would you counsel a patient who is finally losing weight, maybe after years of failing to, and enjoying the weight loss, especially maybe if this isn't the time for it?
Oh, that's a great question. If they're, I've had several who are in active treatment, whether it's chemo or radiation, and losing weight and really enjoying it. I might focus on possible other side effects if they're present and how those can be signs of malnutrition. Therefore, it may not be appropriate to continue to pursue weight loss at this time. I think it's also okay to let them know that there's nothing wrong with weight loss in and of itself, but that pursuing weight loss in active treatment is probably not the best thing to do, nor do we want chemo to be a diet plan. And again, you could ask to meet with them further, maybe when treatment's over, to discuss a better approach to weight loss afterwards through healthy eating or healthy food behaviors.
All right. A couple more. We got some tough questions for you today. Can you speak to any recommendations for tube feeding for a head and neck cancer patient who may have a history of an eating disorder, such as anorexia or bulimia?
I guess I would want to know what kind of recommendations, like how quickly to refeed. Is that what they're asking? Or
my interpretation would just be, would you treat it like you would would you proceed like you would with a head and neck cancer patient who maybe did not have a history of an eating disorder, or would there be any special considerations that you might take, when writing out a feeding plan as far as the progression of the feedings or monitoring?
No, I don't think there would be any different recommendations. Like I mentioned in the slides, you may need to just be cautious about what terms you use around weight gain, maybe saying weight restoration instead of gain if they're sensitive to that term. But as far as progression with calories, that would be exactly the same. And it's definitely, again, as a clinician, it's our job to share that information. It's always appropriate to share that with the patient. I think sometimes we do more harm by trying to tiptoe around the issue and that we're scared we're going to trigger it. But as a clinician, we need to share that information. But maybe do some follow-up. Ask them, how are you receiving this? Or how can I support you through this process?
Thanks. I had a few questions. They were all asked a little differently, but I think the end game was people just wanted to know if you had any approaches to discussing this with your colleagues. So in other words, physicians that might have a patient that is overweight where they'd be encouraging weight loss, but you happen to know there's a history of an eating disorder, or just any type of scenario where maybe you're looking for a weight neutral approach. So any suggestions on how to approach this with your colleagues?
I think, again, like being as forward as possible to let them know the patient's history. And in this case, it may not be best to promote weight loss, but that you as the dietitian will be happy to work with the patient to promote better eating habits or lifestyle choices, but that weight loss may not be appropriate as the primary goal at this time. I think that's very realistic for our oncology population, and I have that conversation all the time with many of my clients that really I just want you to focus on being the best version that you can, treating yourself, emotionally, spiritually, physically, and mentally, that all of that includes health, not just looking at the number on the scale.
Excellent. All right, we have time for one final question. This is one that I was actually wondering about, and that would be, how do you navigate bulimia behaviors when you have nausea and vomiting associated with cancer treatments?
Oh, yeah, that's a great question. There, you're going to have to be very straightforward with the patient. Ask them, and it's okay to ask them if the nausea and vomiting are or if the nausea is triggering the behavior, or if it's eating disorder that's triggering the behavior. I would say too, in this case, it's going to be really important for you to work with them very closely. And if you're not comfortable, then pull in a therapist or social worker who might be able to help get the patient to a place where she can discuss that more openly. That's a very sticky situation. That's a great question. And I'd be happy to discuss that on a personal level if you do have a specific client, and maybe some more information would help me understand it better.
All right, excellent. Thank you very much. I know we do have some questions that we have not gotten to, but we are out of time today. So thank you to everyone who joined. Thank you, Erin, very much. That was very inspirational. I enjoyed the presentation immensely. And just as a reminder, the CE certificate and the slides are both available on the website at www.oncologynutrition.org. And that will be under the member benefits tab up at the top with the new website. So you will have to log in to get that. Again, thank you very much to Erin and everyone else.
Thank you.
Have a good afternoon, everyone.